Nadolsky, and with me today, we got the amazing Dr. Nisha Patel. She's an internal medicine doctor who specializes into obesity medicine and lipidology, which is very similar to my pathway. But she has a very niche focus where she does a lot of help with transplants for livers and now apparently a bunch of other things too. So welcome, Dr. Patel.
Oh, thanks so much for having me, Dr. Spencer. It's so exciting to be here.
Yeah, we wanted to have you on. First of all, we're social media buddies, so if you don't follow her, she's got a great Twitter and Instagram. Where can they find you there?
At Dr. Plantel on Twitter and Instagram.
Okay, because you're into
Yeah.
plants.
Yeah, we
You
like
like
we like the
plants.
plants. Get more plants
Okay,
on the plate.
yeah, plants on the plate. Dr. Plantel, look at that. So she's great. She a lot of same similar stuff that I put, just evidence based, kind of obesity medicine. Very good guidance. So I wanted to have her on because she does a lot of fatty liver disease, which actually has just had a name change. So we're going to go over a little bit like what does it mean, like how to screen for it, how to treat it, and that type of thing. Does that sound good?
Yeah, let's do it.
Perfect. Okay. So first, give the overview umbrella term now that what it's called, metabolic. Uh,
Yeah, it's metabolic dysfunction associated steatotic liver disease, or MASLD, which was formerly known as non-alcoholic fatty liver disease. And I think, the name change really was sparked for a couple of reasons. First off, to remove the stigmatizing language in the word fatty liver disease. We try not to use that type of language when we're talking about disease processes with patients, especially since obesity is often comorbid with this condition. And number two, I think it's really meant to capture that there's underlying metabolic dysfunction with this disorder, right? It's not, okay, your liver stores a little bit of adiposity, or we're going to call this just in medical terms, like that's a medical term for body fat, I should say. And
yeah,
that,
adipose tissue.
something, yeah, adipose tissue. So, it's really meant to capture that metabolic dysfunction. And I think one of the key pieces is that now to diagnose this disease is you not only have to have greater than 5% of intrahepatic or interliver deposition of triglycerides, which is the storage form of adipose tissue, in addition to having some other metabolic dysfunction. So whether that be elevated blood sugar or elevated blood pressure, there is some BMI based criteria and what waist circumference based criteria that's ethnicity specific. We know that individuals of East and South Asian descent tend to develop metabolic, I'm going to call it MASLD, let's just say that, MASLD
Yeah,
at
it's a
lower
hard one. It's
BMIs.
just
Yeah, it's
call
a
it
hard one
muscle
to
because that's what I.
we're going to call it MASLD, yeah, at lower BMI. So we want to make sure we're capturing the full spectrum of individuals that are at risk for the disease. We have to also make sure that there are no other causes of, excess intrahepatic triglyceride deposition. We want to make sure that, these individuals are not drinking excess alcohol, or they
Yeah,
don't have other like autoimmune conditions or medications. So, it's really kind of a diagnosis of exclusion in the setting of the proper risk factors and making sure that, we're really working individuals up appropriately.
yeah. Okay,
Yeah.
so just a quick anecdote. I don't know when you graduated residency, but now it's been almost 10 years for me. So like I can't believe it because I feel like I was just there. But before when we'd see people coming in with liver failure, it would be alcohol. Alcohol is the number
Mm-hmm.
one cause. But there became a shift. And I remember seeing somebody in residency coming into the ER and all the complications of liver failure. She was, I think, throwing up blood and that type of thing because of you get these what they call varices in your esophagus
Mm-hmm.
that can start bleeding
Bleed,
and
yeah.
coughing up blood. So I remember going like, okay, wait, do you drink alcohol? Like, what's going on? She's like, nope, nope, nope. She had, I guess you could say a class 3 stage, depending on the staging, but like end stage, what we call end stage, like obesity. And that was the
Mhm.
only risk factor. I remember that, 10 years ago going, holy cow. And that was it was a big deal because, people think about like, oh, sometimes you get blood pressure issues. Sometimes you develop type 2 diabetes, but you never thought about having your liver fail from having too much adipose tissue. So I thought that was interesting. Could you go over so before I know they just changed the name, so this is really difficult to go over, but like
Mhm.
the overall arching concept, they called it MAFLD and now MASLD, but there are different components within there to where like we really care about cirrhosis. And how do you kind of differentiate and
Yes.
like who to really target? Because
Yep.
I think the assumption is that everybody's going to have, like, once you develop obesity, there's probably going to be some, like you said, some amount of liver fat. And what you can tell me if I'm wrong, you're the more specialist here, but like what we really care about is targeting those where it's going to become really
They're high
pathological and
risk.
cirrhosis, high
Mhm.
risk. Yeah. Could you kind of go over that?
Yeah, you're right. If you look, depending on what paper you read, anywhere from with, so let me back up and say that obesity and type 2 diabetes are like some of the biggest risk factors for developing MASLD. A lot of our patients that we see have obesity and type 2 diabetes. And, you're right. Like we need to figure out who's going to be high risk, because the end stage of this is that you develop end stage liver failure and you come
Yeah.
into the hospital, like you said, because I've seen several patients, they have type 2 diabetes, maybe they have some high cholesterol, high blood pressure, and they come in with just what's called decompensated cirrhosis, right? This is
Mm-hmm.
like a diagnosis they never knew they have, because a lot of people are walking around with MASLD and advanced, what's called MASH now instead of NASH, which is
Yes.
metabolic associated steatohepatitis, which is the other end of the spectrum where there's significant inflammation, scar tissue being formed. And so we want to catch those individuals early. In the US, we don't have like universal screening criteria. And so
No.
a lot of patients, that the way they come to me is that they've had some sort of imaging incidentally for another reason, and maybe we found some steatosis on imaging, and then you're looking at them a little bit closer and you're saying, oh well, they also have these other risk factors, right? And so the first thing we want to do is really risk stratify, like who is at high risk of just progressing from kind of what we call basic steatosis, which is just fat deposition in the liver, to that inflammation that we're talking about. Because it's not everyone. There's only about like 20 to 30% of individuals with MASLD are going to progress. And, that's really where we look at those other risk factors. Do they have a family history? Is there diabetes uncontrolled? How severe is their obesity? What other metabolic dysfunctions, complications do they have? And so there's a calculator or score that we can calculate called a FIB4. It uses some lab values that are available and kind of on some more common tests that you have, that you can get through your doctor's office. And it really can help us risk stratify like who's at high risk of fibrosis. And then those patients actually end up getting, either referred to a liver doctor, or even if like they're an endocrinology clinic or my clinic, they can get if they're high risk, they can get an imaging study, like a fiber scan, for instance, to really help determine like, well, how much, adipose tissue or adiposity is in the liver, and how much, how stiff is the liver, to probably suggest like there's some fibrosis there. And invariably, though, the treatment is really addressing the underlying comorbidities, and especially addressing obesity and addressing the type 2 diabetes, and, trying to reduce the patient's risk of developing heart disease, which still is the number one killer in patients with MASLD and basically around the world, right? So we want to make sure we address those risk factors. And then typically in our program, they follow with the hepatologist if they're high risk, and make sure that they get imaging studies on a periodic basis. Sometimes they need a liver biopsy because, we're trying to figure out, like I said, you have to make sure there's no other causes of liver disease. We don't want to just be like, oh, this is MASLD, when in
Mm-hmm.
reality, it could be something else.
Yeah.
And so we want to make sure that they're followed. Sometimes they need a liver biopsy. But again, the treatment is addressing that underlying metabolic dysfunction. And I think that's where a lot of health systems don't have that proper support. And that's kind of how I got started in my department. Yeah.
Yeah. So yeah, it's kind of interesting because like I notice that people just go, okay, go get a liver ultrasound. It's like, I don't know if that's
Yeah.
the right way. And you look at the guidelines, it's
Mm-hmm.
not really. So like somebody incidentally has some fat in their liver, let's say, and people will just go, they'll assume it's from their obesity. And this is where I would say I don't know if it's ignorance, just not knowing. They're naive maybe about it. They don't really understand it. They haven't really read about it. But that it's the same thing where you see somebody, it's like, I have back pain. Oh, it's from your obesity. Oh, your liver enzymes are elevated. It's
Yeah.
from your obesity. No big deal. Well, it can be a big deal because, as you mentioned, there could be there are autoimmune conditions, as you well
Absolutely.
know.
Yeah.
You want to make sure they're not drinking, sure. But even things like celiac disease and like hemochromatosis, liver overloads,
Hmm.
stuff like that, to where like I think it's good. We should probably start helping primary care doctors screen with these high
Yeah.
risk individuals. But then ultimately, and then maybe, if there should be like a little thing and that goes, oh, they're, all right, I want to click this and make sure it's not celiac or all these other little things, viral hepatitis, whatever, and then get them to the hepatologist or whoever. So it's really been, it's an interesting thing because I really got into it. My brother helped with the ACE
Guidelines.
guidelines,
Yeah. Great
and
guidelines. Yeah.
but like even still, like they changed the name, and
Hmm.
there's people don't know, which fibroscan, like which type of scan should we be using, and then I think the one that I assume you use a fib for. That's kind of what you were talking about,
Hmm.
to for
Yeah.
kind of an initial screening to see who's maybe at higher risk, for this, to determine who gets like a a liver scan. Is that how you do it?
Yeah, yeah. So we usually start with the FIB4.
Yeah.
In my clinic, a lot of the patients come risk stratified to me because what ends up
Okay.
happening is that they get an external referral from a primary care doctor, like a community endocrinologist, to our hepatology department. They get risk stratified, but invariably the treatment is always we need to address the underlying,
Yeah.
metabolic dysfunction. Even in severe, like even in patients with advanced fibrosis, like those patients are still at risk of developing, complications, of course, like
Yeah.
so the end stage liver failure, they can develop de novo hepatocellular cancer, so we
Yeah. That's
really want to be
scary.
aggressive. Yeah,
That's
it's
scary.
scary,
Could,
very
could you go
scary.
over what a fib four is? Just because I say it and
Yeah.
people are listening going, what the heck is a fib four?
Yeah, so a FIB4 is a calculation that's based on a couple of lab tests. So two of your liver enzymes called an AST and ALT, your platelet count and your age. And what it does, you put this number into a calculator and it spits out a number. And typically, if the score is less than 1.3, then it's considered low risk. If it's over like 2.67, it's considered high risk. And in the middle, it's indeterminate. And again, you're just like, okay, great. What do I do with this? And
Yeah.
that's again, you have to look at the other risk factors and look at family history. And sometimes, even if it's not like in the high risk category, you still are pursuing further imaging. I mean, it's not just FibroScan, there's MRI imaging that you can pursue,
Mm,
liver biopsy, like I talked about. Again, we're trying to catch those people that are high risk because
yeah.
we want to make sure they're getting proper surveillance imaging, especially with that liver cancer risk, that end stage liver
Yeah.
disease risk. And, in my department, we have plenty of patients with what we call, well, now called MASH cirrhosis, that have, underlying obesity, and we're, they're getting worked up for liver transplant. But at the same time, we're also treating their underlying obesity and metabolic dysfunction and trying to make sure that they're going to be as healthy as possible to go through that liver transplant. So all of this is to say that the earlier we start identifying and addressing these risk factors and addressing these underlying conditions, I should say, the better.
Yeah. I mean, because
Yeah.
everybody out there is probably going like, well, I want to make sure, like, what do I do? It's like, okay, we got it. If you're listening to this, you're probably with Sequence or considering Sequence. And obviously you could go see Dr. Patel. Where you live?
I'm in San Francisco. Yeah.
So
So I'm
if
in
you're in
San
the Bay
Francisco.
Area,
Yeah.
you could go see her. And so people are like, okay, what do I need to do? I mean, the first thing, this is why we do treat obesity. It's not for vanity weight loss.
Absolutely.
We want to improve your health. We want to make sure you live a longer, like, and not just longer, but higher quality of life. So let's say we can
Yep.
keep you living longer, but because your liver is not working really well, you're short of breath. It's a miserable, it's not a good quality of life. So we want to prevent that from happening. So what we do is, if you're at risk for it, obviously we're going to help you, with your obesity. Now, but if you're at high risk for it, we do want to get you into specialty uh, clinics, like what Dr. Patel has, to make sure that we avoid the very end stage type of stuff, or if we need to, manage those end stage things where it wouldn't have been found before. So I think reasonably, like, look, if you have obesity, let's treat the obesity.
Mm-hmm.
but let's also screen for these things. Your doctor may do a FIB4. We actually have it in our calculations. I added it. People are always like, what are you guys getting platelets for? And it's like, well, this
Yeah.
is kind of the new thing. We're
It's part of
screening
the
for the
score.
FIB4.
Yeah.
Yeah,
That's
and so
awesome.
like, if you're high risk obesity, type 2 diabetes, that's kind of the thing, FIB4, and if you're in this higher risk, it may be reasonable to go further and start getting these liver scans, and then, maybe need to see a hepatologist or a specialist. Doesn't have to be, it could be you. It could be Dr. Patel, who's technically not a hepatologist, but is really into this stuff. What
Yeah.
other things? Okay, so what about dietary factors and
Yeah.
things like that?
Yeah.
Anything
So
like that?
the most effective treatment for MASLD and MASH is treating if there's underlying obesity or excess adiposity. We're trying to really target that 10% of total body weight loss.
Yeah.
We can start seeing significant improvements in the fibrosis and kind of activity of some of the MASLD markers at that 10% total body weight loss. But you can actually start seeing improvements in steatosis, which again is that simple kind of adipose or that fat deposition at 3 to 5% of total body weight loss. So by far, we don't have any FDA approved medications for the treatment of MASLD or MASH, unfortunately, except sometimes in certain patients, vitamin E can be used if they don't have type 2 diabetes, but again, a majority of our patients have type 2 diabetes. So treatment is treating the underlying obesity, but there are actually some, what I consider weight neutral dietary and lifestyle factor changes that in studies have been shown to potentially improve hepatic steatosis. So one of those things is that, if an individual is eating foods that contain a higher amount of saturated fat, they would benefit from actually replacing that with plant, polyunsaturated, monounsaturated fat. There's the thought that there's some evidence that the liver deposits, kind of preferentially deposits intrahepatic triglycerides more from saturated fatty acids, essentially. And so we don't want people, consuming excessive amounts of saturated fat. This is not the time to put butter in your coffee and eat those ribeyes if you have MASLD or kind of advanced disease like MASH. And so switching to those plant fats is really helpful. Of course, I'm a big proponent of plant-forward dietary patterns. I think, increasing fiber intake, that can also help with weight management. Those are pretty important overall, in line with basically every national guideline that you look at. There's also some evidence out there that just high intensity aerobic exercise can really help kind of repartition some of that adiposity out of the liver. And so if you're able to do that, really kind of kick the intensity up. And it's not just like you do it once a week, it's something that you have to do at a higher interval for a longer amount of time. What else was I thinking of? But those are kind of the major kind of dietary improvements / lifestyle improvements. I'm a big proponent of resistance training. I know you are. It's always better. It's always good to increase your muscle mass, and prevent frailty, and improve your mobility, and also help with your muscles, like a big sink for blood glucose. And so you definitely want to make sure that you're activating your muscles and exercising. And so, those are kind of the big treatment options, and they go all hand in hand. A lot of my patients, actually all my patients, have underlying obesity. So we are working on those health promoting habits and working on creating a health promoting dietary pattern that includes all of these principles. I do worry about the individuals that are pretty adamant that they want to do a keto diet and they have advanced MASH and they might be losing weight, but I actually am concerned that because of the higher, even though we're trying to work on reducing their saturated fat intake, but because they've been exposed to that higher saturated fat intake, that they're probably seeing a blunted improvement in their actual activity of their MASH. A lot of these patients have advanced fibrosis, and I'm like, or maybe we should switch to a different dietary pattern.
Urge some caution. I mean, it's really funny because every time we talk about what are the dietary and lifestyle things we should do for XYZ comorbidities or sequela, the consequences of obesity, they're all kind of similar. Cardiovascular disease,
similar.
probably good.
Yes.
probably good to eat some plants, some weight, do
Yeah,
some
eat some
exercise.
plants.
Oh,
Yeah, eat lean proteins if you're eating animal products. Like, yeah,
yeah. Yeah,
yeah,
liver. Probably good to eat some. It's all very, very similar, and we're treating the underlying obesity. I will say, like, you know, probably a good idea not to drink sugar sweetened beverages. I
yes,
wouldn't worry about
absolutely.
people talk about fructose. Fructose,
Oh
for anybody
yeah,
listening,
fructose. Yeah,
the
I know.
people fructose is metabolized differently in our body compared to glucose. And I don't want to go through a biochemistry lecture here, and I'm not the right person to do it. I know enough to be dangerous, I suppose is the word, but it is metabolized differently. But so people think that we should avoid all fructose. Well, the thing is, like, and so that means avoid fruit. The thing is, fruit, first of all, it's a
Yeah.
combination of glucose and fructose, and the underlying mechanism is truly like an energy excess. Fruit helps you eat
Yep.
less energy because it's nutrient dense and not calorie dense. It's you can eat a lot. It can actually help you lose weight. So, like, unless you're I just wouldn't drink sugar sweetened beverages. And that's anybody
Yeah,
with obesity or anything there. So, like,
absolutely.
I know people are going to ask about that. So diet
Oh, fructose.
sodas,
Yeah. Oh
drink diet
gosh,
sodas,
that
drink water, whatever. I don't care. Coffee
I mean,
without
there's nothing wrong with diet sodas, especially when it's replacing a sugar sweetened beverage in your dietary
yeah,
pattern. Like, it's like, I always get really like worked up about this because I think people forget that we live in the real world, and like the
yeah.
real world is so different from this like echo chamber of social
Bubble,
media, and
social
it's a
media.
bubble.
Yes.
And then the other thing I want to say about fructose is a lot of people don't understand that like we don't really just eat fructose by itself with the food
Right.
supply. Like fructose is, like high fructose corn syrup is
Yeah.
actually
It's
almost half, yeah, like
almost half
glucose,
and
half
half. Yeah.
fructose. Yeah. So,
Yeah.
and then, fruit has fructose in it, but like you said, we're not worried about the fructose or the sugar in fruit,
Yeah.
and so people just don't understand we're not like eating gobs and gobs of fructose by
No.
itself. It's just, and it's the source of where that sugar is coming from is the most important part. And
Yeah.
definitely think that, replacing regular sodas with diet sodas is a strategy to help reduce calorie intake, right? Like
Yeah.
this is the real world. We live in the practical real world here.
This is the real world on Beyond the Scale. We're not in internet like social media world.
Yeah.
Yeah, if anybody wants any fun, you can see some of the comments that after Dr. Patel posts, and I mean, of course, my comment section is always a fun if you have thick skin, I suppose.
Yeah.
Place to be.
A lot of
Thank you so much
keyboard
for
warriors
coming
out
on.
there.
Yeah,
Yeah,
keyboard warriors.
absolutely. Keyboard
I
warriors.
love the discussion. Thanks so much. Yeah, I think this is a really important topic. People still think of obesity as just like vanity and then maybe some cardiovascular disease and stuff, but like the liver becoming a
Yep.
very much more prevalent, I should say, a
Number one
disease.
cause
Just
of liver transplant in people over the age of, like 60 or 65 and in women. And I think that's only going to
scary,
continue to get worse. Yeah.
scary.
Yep.
Thank you so much for
Scary.
coming on, Dr.
Yeah,
Patel.
absolutely. Take care. Okay. Bye.